Hospital-based violence intervention programs, or what I will call HVIPs, are complex interventions that basically try to leverage public health institutions to break cycles of community-level violence. And so what that means is take basically your case manager, your community health worker, your patient navigator, and a social worker. Slam them into one role, find someone from the community with a lived experience of violence, place them in that role. Take that complex role, that person with a complex life experience of violence, and put them adjacent to a hospital emergency department or trauma center with a twofold goal. One is to de-escalate desires for retaliation when loved ones come in to see the person who may be admitted to the hospital with a violent injury. And two is to go to the bedside and offer an invitation to come and say, I'll walk with you as on your journey to heal outside of a life of violence so you're not re-exposed and readmitted to this hospital with a violent injury. These are very complex interventions. They're also very young. Of the 715 trauma center, level 1 and level 2 trauma centers I've scavenged, I've found 140 of these programs, 4 of which predate 9/11. The median program was founded in 2019, which means that fully half of all programs were founded immediately before, during, or in the shadow of the COVID-19 pandemic, when emergency departments and ICUs were slightly busy. But the bodies did not stop coming in to the ER. That actually violence rose during the pandemic. And so instead of sweeping it away, the pandemic actually swept more people into the ER for violent and penetrating injuries. And so what that means is that these programs, didn't have a concrete model of implementation to be faithful to. There's no fidelity to a shared model or blueprint during this time. The implications of on this side of the pandemic, meaning we fundamentally do not know how to sustain these programs. That were implemented differently, in different contexts, in a way that was not the norm for their predecessors before them for the previous number of years. And so what do we do? And so one of the things that I did is I gathered a group of experts in the field, folks who have been operating or founding long-running programs, the programs that were kind of pre-pandemic initiated, and got together and said, let's go through an iterative process. Help me figure out what are the core factors and drivers of sustainability for your programs, and let's see what we can do and try and embed some of that in the DNA of these younger programs. And so we went back and forth, and over the course of a number of months, identified 28 different important factors, or factors that were important to the sustainability of these programs that have made it, that have long been established. And so they went through some nerdy math and what's called Bayesian hierarchical analysis and a maximum difference scaling, and basically had a process where I asked them to pick their favorite child. And said, of these 28 things you love, these 28 things that are the most important to you, to sustaining your program, what's the most important and the least important, right? Who's your favorite loved one? Who's your least favorite, right? And the process actually ends up putting these things you love against in competition with one another to try and separate them out, to mathematically put your values on a ratio scale. So you're not listing them 1 to 28. You can actually say, number 1, which is funding for your frontline hospital violence prevention professionals, is actually 1.7 times more important than funding for general operating support. And as a former grant writer, that anything is more important than funding for general operating support is bonkers, right? I can also say that number 2 out of 28 is the characteristics of your frontline violence prevention professional are 5.75 times more important, according to the experts in the field, than your community champion who got you in the door. And as we love community-based participatory research, as we love engaging the community, that the nature of the intuition, how this person operates under pressure, what they do with a tight caseload, the characteristics that define this person, with a lived experience of violence stationed in this area, is nearly 6 times more important than your community members. It doesn't mean the community is not important, but it's things out of these things that are all important. This is insanely important. And the issue with that is in the earlier part of my dissertation research, I studied the things that help or hinder the early adoption of these programs. And what's challenging now is the things that I just mentioned, that are on the lower half and the lower end of the value and importance scale are the things that are actually the most important to get your program started. So the things that get you in the door and get your program started and the hospital to begin with are the things that actually, come lower in value later and are superseded by other things. So what does that mean when people are flooding the ER, when violence keeps happening? Because we have the best trauma surgeons in the world. We know how to stitch people together. We don't know how to prevent bodies from coming into the ER in the first place. And we certainly do not know how to prevent them from coming in again. And so what do? When the values and the priorities that get you in the door to establish one of these programs are not the things that will sustain them. Right? And so what happens is what now my job is to try and figure out is how do we make that transition to where the thing is we're paying people for their trauma to come re-engage people in the crucible of their trauma with the goal of extracting them from that life of violence where particular risk factors and social determinants might lead them back to a repeat injury. Right? Those are the most critical because 4 of the top 5 and 6 of the top 9 of 28 different factors led to that person on the front line, which is not the first priority when you're trying to get funding from your hospital, when you're trying to get the C-suite to buy in, when you're trying to get the community to say, hey, trust us. And so the issue now is, how do we take this information and try and figure out how to adapt from the beginning, right, into adjusting, to recalibrating, into where we are now. Because this week, the Trump administration terminated $150 million in community violence intervention contracts. And so we're going to have, a real world test of how these values work and where these priorities land. And the issue is, with all this going around and threats to the very structure of how we engage these programs, that the key focus, what we're realizing is, the folks who are on the front lines, at the bedside, who, do not need a belt tightening and a caseload expansion. That if we want to sustain these programs, what we actually need is to create a culture of rest, of restoration, and of recalibration, even in the midst of a chaotic system, in order to break cycles of violence using and leveraging healthcare institutions instead of law enforcement and punishment and the traditional mechanisms that have failed us so far. So, thank you.